It is my pleasure today to have Dr. Catherine Brown with us to talk small bites, big impacts, navigating vector-borne illness and public perception. Dr. Brown is the state epidemiologist and state public health veterinarian at the Massachusetts Department of Public Health. She completed her Doctor of Veterinary Medicine at the University of Minnesota, a Master's of Science in Wild Animal Health from the University of London Royal Veterinary College, and a Master's of Public Health from Boston University. After a decade of clinical veterinary practice, most of them in urban wildlife medicine, she was awarded a CDC-funded CSTE Applied Epidemiology Fellowship at the New York State Department of Health. In her role as the state epidemiologist, Dr. Brown is responsible for overseeing surveillance for over 90 reportable infectious diseases, as well as guiding surveillance, data analysis, and dissemination. She is passionate about collecting and using data for public health action and recognizes the critical importance of data sharing across public health sectors to advance health equity and improve the lives of individuals and communities. And this is my addition, she's also a fabulous speaker who's able to take some complex topics and break them down in a way that's easy for all of us to understand. So thank you so much, Dr. Brown, for being here with us today. We'd just like to acknowledge that these webinars are funded by the Administration for Strategic Preparedness and Response. And if we go to the next slide, the content of this is not representative of the official policy or position of the US government and is not meant to be a substitute for medical professional advice. But we are excited, and I'll hand it over to Dr. Brown.
Great. Thank you so much, Eileen. I really appreciate the invitation today. And we're actually going to talk about a couple of things that are a couple of diseases that remain sort of some of my favorites. And one of the reasons they're my favorites is because they are so complicated to talk about. And so I'm interested, I'm happy to share sort of what the way I do things and kind of what I've lessons learned over the years. And I very much hope that it will be somewhat helpful and interesting to all of you. But I'm also hoping to get through it quickly enough that we'll be able to do some Q&A, because I certainly do not have all of the answers, and would definitely be interested in all of your thoughts on this. So we're going to focus on vector-borne diseases that occur here, primarily in Massachusetts, but also it will affect most of Region 1. And definitely talk about how we do surveillance for mosquito-borne disease as opposed to tick-borne diseases. And then I can talk about how we use the surveillance data to really inform kind of the risk communication that we do. And as I do that, I will definitely be talking about some of the real challenges that we have with public communication for these two different kinds of vector-borne diseases. I do just want to be clear, I'm not like trained in risk communication, but I've been doing it for 20 years. So I'm sharing my experience as opposed to sort of like core principles of risk communication. There's plenty of materials about that online. And so I didn't think that that would be the thing that was like most helpful or interesting for all of you. The other thing is I realized this is a more clinical audience. And so I am going to, there's a few slides that are probably fairly basic to you, right? You already know a little bit about these diseases that I'm going to talk about. But the reason I'm continuing to include them in this presentation is simply because it's part of how I talk about this with different audiences. And so I'm using it sort of as an illustrative, using it for an illustrative purpose. Okay, so you heard from Eileen that I actually have a master's of science in wild animal health, and I'm a veterinarian by training. And so I have to say that probably no matter how long I stay in public health, vector-borne diseases are going to remain some of my favorite. And it's because they are so complex and they arise out of environments that are very complicated, difficult to predict, hard to understand, and even harder to explain. And so, yes, I understand it's a little weird to say that that's why I like it, because they make my life difficult, but that is absolutely true. And one of the things that I use sort of as a setting the stage when I'm talking about this is to help people understand why it's so complex and why it's so hard for the Department of Public Health to make predictions about how bad a particular season is going to be. Like, this is where I start, which is that vector-borne diseases require 5 different things essentially all together in order for a vector-borne disease to exist, right? So they have to be in the same environment. So the environment is the big starting place. And I don't define the environment sort of more specifically on this slide, but we'll talk about it for the different diseases. But within the same environment, vector-borne diseases transmit only when there is a competent vector, so a type of, insect or arthropod that is capable of spreading the pathogen. The pathogen has to be present, right? Because the vector in and of itself is not sufficient. You then also need a reservoir host. So where does that pathogen originate? And you need a susceptible population. And in this case, what our susceptible population are humans, right? And if we don't have all of those things in an environment all together at the same time in the same place, you actually disrupt the vector-borne disease. Now, that sort of makes it sound easier than it is, but I do find this framework useful for people to sort of understand perhaps why something like dengue might not actually end up circulating, really well in Massachusetts, because we can talk about the competent vectors. We can talk about the amount of pathogen that is, in our environment. We can talk about how that cycle gets disrupted. But what we're going to talk about today are actually diseases that are found here. And I'm going to start with the mosquito-borne diseases. And, the 2 primary ones that we think about in Massachusetts are Eastern equine encephalitis, Triple E, and West Nile virus. I'm showing them both here on the first few slides, but then I'm really going to focus on Triple E for several reasons, but partly because I think it makes a good contrast to our tick-borne diseases, which we'll get to a little bit later on. So most of you will be, I think, relatively familiar with this. We have Triple E and West Nile virus are, both spread by the bite of an infected mosquito. The incubation period is somewhere between 3 and 14 days for each of them. But the disease manifestations are largely different, right? So West Nile virus tends to, for most people, cause a milder subclinical infection. 20% have a fever, headache, chills, muscle aches, fatigue thing. I used to underplay sort of the severity of this, febrile illness, but when I talk to cases, I hear that it can actually be pretty miserable. And then it's really a very small proportion of people who are exposed who will develop, the neuroinvasive form of the disease. We think it's fewer than 1% of folks who are affected with that. And that's really in strong contrast to Triple E, where the jury's a little bit out on whether there's much kind of subclinical infection. The recent research that's been done in this area actually does not support a lot of subclinical infection, but we could debate about that at another time. But when you see symptoms, it's usually a very abrupt onset, starts the same: fever, chills, headache, muscle aches, but the virus is pretty much always neuroinvasive, and so it progresses pretty quickly, to include symptoms of meningitis and then to often meningoencephalitis, so progression to seizures, coma. And in Massachusetts, we actually see somewhere between a 30 to 50% mortality rate for people who have symptoms. It's a very severe illness. And even when you survive, 80% of those who survive are left with some level of permanent neurologic damage. So it's very significant. And one of the things I want to call out about Triple E is that, it does affect our children, right? And it can kill them. And that's actually an important factor when it comes to risk communication and how people sort of pay attention to this and absorb information. So this slide just shows the last 7 years of our history in Massachusetts, with both Triple E and West Nile virus. And I want to draw a couple of contrasts with this, and it again helps explain why we're going to talk about Triple E primarily. So one of the things that I think you can appreciate here is that for West Nile virus, we see human cases pretty much every year. We've had a few years since it was first introduced into this country where we haven't had any cases, but that really is the exception and not the rule. Whereas with Triple E, we tend to see much more episodic activity. And so we had, I don't know if you all remember, I unfortunately remember 2019 very distinctly, and that's despite the intervening pandemic years, where we had 12 human cases and a 50% mortality rate, which is, 12 human cases may not sound like a lot, particularly when it was followed immediately by COVID, but that actually is a huge number of cases in a single year. And it was our worst year in Massachusetts since the 50s. But then it was followed by, 3 years of no cases, 21 through 23. In 2024, we had 4 human cases, only a 25% mortality rate that year. And we were afraid that that was the beginning of another sort of episodic cycle for us for Triple E. But last year, we did not end up having any activity. And it is hard to predict what's going to happen this year, but some of our indicators suggest that this may not be a very significant Triple E year. So keep your fingers crossed for me, please. With Triple E, as opposed to West Nile virus, because of the severity of the disease, and in large part, I think, because we have children who are impacted, there during our severe years, when sort of normal personal prevention techniques are not sufficient to reduce human risk, we do, the state does sometimes use aerial applications of pesticide, adulticide, to kill adult infected mosquitoes to help reduce the risk from Triple E. And you can see that in the last 7 years, we've actually had to do that in 3 of those years because of the amount of Triple E activity that we had. Aerial spraying is not a tool that is particularly used for West Nile virus here, and there's a lot of reasons for that. Again, that's not really going to be the focus of what we talk about today, but I do just want to sort of highlight that distinction. So, really important, I think, when I'm talking to people, to help them understand how our control measures, the control measures that we do have for mosquito-borne disease, how they actually can work and how they are applied during the different timing of a mosquito season. It's important for, I think, people to really understand how this cycle works. So again, I'm going to sort of focus on triple E here. So triple E is a bird virus, right, primarily. Triple E evolved, the virus evolved in this environment, so it doesn't tend to kill our native songbird species that it exists in. Although that's, it's not 100% true. It does kill some of them. And more importantly, it does kill our non-native bird species. But so it's not like West Nile virus where we can see die-offs of birds that would be like a trigger for us to know that maybe we have the virus in our environment. And so at the beginning of a season, we know that birds migrate up from the south. I'm happy to blame Florida for most of this. The genomics of the virus suggests that that's where a lot of our triple E comes from. And so some proportion of the birds fly up, they're carrying the virus. And then there are bird biting mosquitoes. So one particular species that really prefers to feed off of birds rather than anything else. And when they bite an infected bird, they pick up the virus. And then when they go to bite an uninfected bird, they can pass that virus along. And so again, at the beginning of the season, there's really only a few birds that are carrying the virus. But as more and more mosquitoes get infected and spread the virus to other birds, you can see that we're going to end up with a larger and larger proportion of both birds and mosquitoes that are infected in the environment. And this is called our amplification cycle. And the degree to which the virus gets amplified during this portion of the cycle, which tends to occur sort of June, July, maybe into early August. The amount to which that amplification happens is, dependent on a bunch of different things, but partly the number of birds that, come up with the virus, and then also the mosquito populations. Now, what does happen at a certain point, and we don't have a good way to measure sort of what is that threshold. But at a certain point during some years, there will be enough virus in this environment, and it's being carried by mosquitoes and birds, but it's all in the same environment. That a species of mosquito that prefers to feed off of mammals, but if they get hungry enough, they'll bite birds. They will end up biting an infected bird, pick up the virus, and then when they go to feed off of a preferred species, a mammal like a human, they can end up transmitting the virus. And this is our spillover phase of the cycle. So humans don't serve to perpetuate the cycle at all. It's not like other mosquitoes will bite the human, pick up the virus and pass it on. That's not what happens. It's just that there's enough virus in the environment that these mosquitoes that rarely feed off of birds will feed off of one, pick up the virus, and then can pass it along. And this really is just sort of like an incidental transmission, and it helps to explain why triple E is relatively rare. So the opportunities for doing adult mosquito control interventions, both ground-based and aerial, really only, it can start in June, usually a little bit later, depending on our temperature. And then it really only goes through the beginning of September, and I'll show you why later. Triple E is special in Massachusetts. This is the number of cases nationally by state of residence, not state of exposure. Just to be clear, Montana is not a hotspot for Triple E. But I just really want to highlight that Massachusetts is unfortunately blessed when it comes to Triple E, and we have had more cases, more human cases than anyone else, and they have been exposed here. And we can understand why that happens because that environment where the birds carrying triple E and that bird biting mosquito, Culisata melanura, where they live all together is in Atlantic white cedar swamps, right? And so, yes, this is an old map, but it helps, I think, really explain the distribution of most EEE activity. And you can see from the green coloring that that is the sort of original distribution of Atlantic white cedar swamps along that northern Gulf Coast. In Florida, in the Panhandle, and then along the East Coast, actually all the way up into Maine. And you can see that in Massachusetts, those swamps are focused on southeastern Massachusetts. So just showing you fun pictures of what those swamps actually look like in real life. And then this is the bird biting mosquito that is responsible for the amplification part of the cycle. And then to complete sort of the environment in which EEE actually is successful, right, as a pathogen, those swamps are often adjacent to cattail marshes. And cattail marshes are where this second species of mosquito, Coquillettidia perturbans, which is more of a mammal biting species, where they actually breed and live in cattail marshes. But again, if that's adjacent to a cedar swamp, then the infected birds are sort of all sharing that same environment. Again, think back to that slide about what makes a successful vector-borne disease transmission is the environment plus the pathogen, the vector, the reservoir, which is the birds in this case, and then the susceptible populations. Now, you might say, well, humans don't live in the swamps, and that's true, but I will tell you in southeastern Mass, they live around the swamps. And so you can actually see that over time, that the majority of our EEE cases have occurred down in Bristol and Plymouth County, again, where we have the largest focus of those white cedar swamps. But it is not exclusive to there. And we have seen over time, again, something I'm not going to spend a lot of time talking about today, but I think it's important. We have over time actually seen a broadening of the geographic expansion of where we see human cases, and in fact, where they are actually infected locally. I will say Martha's Vineyard, that individual from that location was not exposed on Martha's Vineyard. And this is just one of those oddities about public health surveillance, which is that we, as a standardized practice, we count cases based on residents, not necessarily anything else. So EEE is so important in Massachusetts, right? Because of the number of cases that we see, right? Again, we're special when it comes to EEE activity. And again, I think in large part because we have seen so many children affected over the years, that there is this statewide multi-agency arbovirus kind of surveillance and response that addresses the risk of EEE. And, just want to highlight that it involves multiple state departments, public health, ag resources, conservation, recreation, environmental protection, and then it definitely involves our local experts as well, both local public health and our local mosquito control districts. And in fact, there are two separate state plans for this. One is the public health plan, the Massachusetts Arbovirus Surveillance and Response Plan. Sorry, we actually have our 2026 plan posted. And then the Department of Agricultural Resources, which is where mosquito control sits in the state, Authority for Mosquito Control. They have a plan that outlines what will be done in the event of a large outbreak of EEE and how we respond to it. So fun plans if you ever need help sleeping at night. They're both long, but very informative. So at the Department of Public Health, we are focused on three different things. One is surveillance, and this is not just mosquito surveillance, although that is obviously very, very important for us, but it's also doing the laboratory testing for the mosquitoes, for possible infected animals and possible infected humans, okay? And then we take all of that information, the surveillance information from both people, animals, and mosquitoes, and we turn that into risk analysis and communication. So our goal is to use those data to identify areas at risk for human disease, communicate those findings broadly, like where we think the risk is greatest, and then also provide information to guide control actions. So our goals of surveillance are really twofold. One is to detect the presence of virus as it emerges. So we always start doing mosquito testing in the middle of June, which is earlier than we expect to find either EEE or West Nile virus, but we want to find it when you know, as early as possible when it first emerges. And then we want to sort of track how rapidly and where it is spreading to, because the broader the geographic area over which risk increases, the more likely we are to see an outbreak. Not going to spend a ton of time on this, but I do just want to highlight how labor-intensive mosquito surveillance actually is. There are multiple types of traps that are used, that you have to go out, set them in the right environments to trap the right kind of mosquitoes. And then when the mosquitoes are brought back into the laboratory, you have to count them because we use that as a measure of population. And then sort them by species, because we don't care about every single kind of mosquito. There's 51 different species in Massachusetts at least. We really only care about the ones that are most likely to be involved in spreading EEE, and then we test them. And so it is a very intensive system, and I just want to, you know, express my gratitude to everybody who's involved in that, because it's so critical. And this is the type of data that we get, right? So yes, this is kind of retrospective, but what I want to show you is that in general, we have pretty good correlation between the number of samples of mosquitoes that test positive for EEE and our numbers of human cases. And, you know, our goal, of course, is to find the mosquitoes first so that we can start to, you know, inform people about the risk. But again, I think over time, this has shown, and we've been able to refine the way the way we do the surveillance for mosquitoes in a way that I think shows that the correlation is good. It's not perfect, but it's good. Okay, so here's where we start to take some of the information and turn it into risk communication. So we maintain a website where we will place all of the information that we can legally share about positive mosquitoes that are found, the species, the city or town where they're found, and the dates. And then also information about confirmed animal infections and confirmed human infections. And we take all of that information and we combine it with historical understanding of how the virus tends to emerge and geographic areas that tend to be at risk. We combine it with an understanding of what sort of the climate factors are that particular year, and are they likely to support EEE activity or not, and then also timing of the season. And we create risk maps by city, town. Now, I know mosquitoes do not respect town borders. It's a little bit artificial to do it that way, but it also helps explain, and it's why sometimes our risk area looks maybe bigger than our mosquito findings might suggest. And it's because we're taking not just the mosquito findings from that year, but also our knowledge of the environment in that area, the climate, the historical sort of expansion that we see. And we pull that all together and use it to inform this risk assessment process. You know, this is actually, I think, what the map looks like right now. We're at the beginning of the season, so not high risk for anyone. But on the risk map, right, we do use color coding to help sort of people understand as risk increases. We go from soothing blues and greens, right, to the more alarming kind of yellow, orange, and red, and that is purposeful. I don't think we actually want people to be alarmed, but it is one way that we can use some of the visuals to just sort of help people understand, okay, this area, this is the oranger colors, this is where we need to worry more, and then in these other areas we don't. But it's not helpful to tell people sort of where risk is unless we can also give them something to do about it. And so at each risk level, we also provide recommendations. And this one is just sort of recommendations for, individual, for people. But our arbovirus surveillance and response plan also includes the recommendations for public health departments, for mosquito control districts, and for the state when we have to start thinking about, is risk getting so high that we need to do some type of larger aerial spray response. So one of the real challenges with vector-borne disease prevention in general, and I'm highlighting this because we'll talk about it again with the ticks, but is that it really relies on personal actions, right? We want people to go to a website and look for information about, where things are happening. And then we want them to do particular things to help reduce their chances of being bitten by mosquitoes. And we have all worked with people long enough to know why that's a challenge. And I'm not going to go into sort of explaining that to you, right? But asking that of, every individual is complicated and not always entirely successful. So we do try to, this is a graphic that I've developed over the years. It's been modified multiple times to sort of help people understand kind of where we are in the risk escalation cycle, and then also what are the different tools that maybe we have at different parts of this cycle. And this is useful because there are stages, right? Like I can point out that, hey, you know what, being aware of where mosquitoes are infected this, right now, and then taking these steps, repellents, clothing, and potentially avoiding peak mosquito activity time outdoors, right? Those are things that I can point to and say, look, even when risk is low, these are things that you can be doing to protect yourself. But the other thing I stress to them is that this is like the foundation. It's not like, once we get to a higher level of risk, you can stop doing those things, right? This is the foundation. So personal prevention is the foundation of all risk reduction for mosquito-borne illness. And that's exactly how I say it. I'm sure the press is tired of me saying that. But then as risk increases in some areas where there's a mosquito control district, there will actually be ground spraying to kill infected adult mosquitoes. And then as risk increases even further, there may actually be that aerial spray. And again, like all of the things, as you advance along this cycle, all of those things should be happening. It's not an either or. So I'm going to just highlight what 2019, because again, I mentioned this was such a really bad year. And so once we got through it, we pulled together, the multi-agency working group and, some members of the public and local boards of health and everybody to try to talk through what have been our challenges that year. And so these are the communication challenges, right? It's a rare, very rare, but very serious disease, and different groups of people respond to that differently, right? So if you have a family member who's been affected, then the fact that it's a serious disease is the one that sort of weighs heavily on you. But for families that are really invested in sports and want to do outdoor activities, and we're telling them maybe there's this risk of a very serious but rare disease, they actually focus on the rare part of it as opposed to the serious part of it. Already said is driven by this very complex ecological cycle that is very difficult to explain in layman's terms. And the question I always get is how many mosquitoes have triple E right now? And there's no answer for that, right? It doesn't happen every year, which is a benefit and a challenge. So the fact that it doesn't happen every year means people forget and they have to like relearn the whole thing next time we have an outbreak. On the other hand, complacency, when you have something that happens every year, you tend to get complacency build faster. Already mentioned, prevention relies on action by every individual. That's really problematic. And then there are these misconceptions that risk is localized to where that mosquito was trapped, right? Like where I have a data point, that's where the risk is actually greatest. And because the environment is what triple E comes out of, it's much more complicated than that. In some ways, people will believe that mosquitoes respect town borders, and if they just go hold their soccer game in the town next door, they'll be safe. And then aerial spraying, there are two groups of people, either those that think that, you know, we should aerial spray all the time because it just fixes everything, and there are the folks that think aerial spraying is ineffective. So just a few additional challenges. So there are so many audiences, so many groups you have to reach when you're talking about this. And I will tell you, everybody thinks they should know what's happening first. We have often had struggles over the years, like who decides when to put out a press release? Is it public health? Is it local public health? Is it state? Is it, you know, the governor's office? Like how does all of how do all those decisions get made? It's also defining sort of how the criteria that we use to change risk levels is complicated because some of it is science and some of it is art. There are risks and benefits to broad scale pesticide use. There's always a delay between risk identification and the ability to launch an aerial spray response. And so communicating about that delay is hard. Killing juvenile mosquitoes, which of course before they become biting scourges, is always something that you want to do, but that's actually really hard with triple E because of the swamps. And then we have the issue of people wanting to know if their area was sprayed, when it was sprayed. And then also multiple agencies are getting questions and we want to try to provide standardized responses. Okay, I have to go faster. So here's the deal. What we did in response to a lot of these sort of challenges that we faced, these are some of the things we've done, and we continue to use them because they've been largely successful. So one is that we have specific triggers for press releases. It's written into our arbovirus surveillance and response plan, and we sort of remind everybody, here's the way we do this, here's why we do it, and then we get everybody to sort of remember that before the season so we don't have to have the discussions as we go along. There's also we have tried to be sort of more transparent about how we make decisions for aerial mosquito intervention. Like, what do we look at? And so mosquito abundance, infection rates, we look at the geography, we look at the weather, and we look at the time of season. And in fact, we have taken to showing this graph on the right, which actually shows you sort of the average population of that mammal biting mosquito, the one that tends to spread triple E to humans, by week, and looked at it over different years. Now, what you can see is that there's variability every single year, but by sort of mid-September, that population is really low. And that's important because it doesn't mean, unfortunately, that there's no risk. It means there's less risk, but it also means that doing an aerial spray that late in the season is not likely to be terribly effective because there just aren't that many mosquitoes around anymore. So we try to use data to help explain that. We also have specific talking points about the aerial application of pesticide. It's the same product that's used by a lot of our mosquito control districts from ground. We talk about the fact that you use an ultra low volume of this. It's a 0.62 ounces per acre, so like a shot glass over a football field. And we also have to talk about the fact that though it can be effective, it's not like a permanent fix. It's kind of temporary. And it isn't going to prevent every single case of triple E. And so people still need to do the personal prevention things. We have leveraged GIS tools to be able to have maps where people can actually search their address and find out whether they were sprayed or not. And that has been a game changer for helping calm people down so they can actually find the information. And then we've also looked at our emergency department data to see if we can find evidence of an increase in asthma-related or chemical sensitivity-related visits to emergency departments associated with any of these aerial spray events. And consistently, we don't find that that is happening. So again, trying to use data to help sort of explain some of our talking points. We've also increased our transparency around our measured efficacy from aerial sprays. So there is like a whole effort to try to figure out what proportion of the dangerous mosquitoes were killed during an aerial spray. It's a complicated scientific, pre-post trapping comparison, and there's a math formula and everything for it. But then so that we can show people, look, yes, this really does kill a significant proportion of mosquitoes if it's done correctly. But also by sharing kind of the temperature range and the humidity and how quickly an aerial spray happened, we've actually been able to learn lessons that will help us make aerial spray more effective, or have helped us make it more effective in the future. So the warmer the temperature, the better. The more humid, the better. The earlier in the season, the better. And kind of the smaller the area you do so that you can get it done in 1 or 2 nights, as opposed to having to try to cover it over multiple nights, also improves efficacy. So I'm just going to end triple E with this. So again, these are our Atlantic white cedar swamps. And this is a really nice quote from a good paper. So we had a lot of Atlantic white cedar trees. They were harvested during sort of colonial periods, and the wood was used for all kinds of things. But then as they've been reestablished and we've been bringing them back, we have recreated this perfect habitat for triple E. And so I'm not saying it's our fault. I'm just helping to sort of explain sort of the environmental changes over time and why we might be seeing increases in sort of the more recent decades in triple E activity. And then that's like a good place to then move to the tick-borne diseases, right? So we really did decimate the forest. We humans decimated the forest when the settlers arrived to, Massachusetts Bay Colony, even before it was that, right? And we cut down all of these trees. We needed them for building and cooking and all of the things. But then, we also, as human beings, have decided we actually like the forests and the trees. And so we've been reestablishing some of that environment, and we don't need as much agricultural land anymore. And so we went from sort of decimating the trees so that there was only 30 to 40% forested land, going back up to around 80%. And in addition to that, in addition to reestablishing the forests, we've actually sort of we now live in the middle of them, right? And so we've created these kind of Swiss cheese forests where we have, some houses and a little bit of a, in the yards where we've landscaped our yards, cut down the trees, but then we're surrounded by these forests. And it's really that fragmented forest habitat that has created the perfect situation for our where we are with tick-borne diseases. Okay, so this is the sort of environmental explanation for why we have so much tick-borne disease. And essentially, by recreating the forest in this modified form, and I'm simplifying this a little bit, but by creating these forests in this modified form, we've actually have way too many host species that ticks feed off of to sustain their population, and we don't have enough predators anymore to reduce those populations of hosts. And it's this imbalance that we think has really contributed to the explosion of tick-borne disease over the last 50 years. So I'm going to, we have a lot of tick-borne diseases in Massachusetts. Mostly what I'm going to talk about is our black-legged or deer tick and Lyme disease, because that's the one that's been here the longest. And so risk factors for tick-borne disease, particularly Lyme disease from black-legged ticks, is this fragmented forest environment, which has expanded the habitat that these host species like. And so it has resulted in an increase in the deer population, increase in the white-footed mouse population, which therefore increases the tick population. Because of all of that, and because these host species, at least the mice, are also the reservoir for the Lyme disease pathogen, right? We've ended up with amplification of that pathogen. The tick spreads it between the mice, and we get more and more infected. And we have more people exposed to the tick habitat because, again, they're living in this Swiss cheese fragmented forest habitat. So although, again, we have really 3 different tick species of concern, I'm focusing primarily on our black-legged ticks. And you can see from the picture down here on the right, like how absolutely tiny this little nymph is. And that is the nymphal stage. And that is actually one of the problems, right? Is that it's so small, it's easy to miss and can end up biting you and spreading disease. So again, here's the list of all the tick-borne diseases that we really think about in Massachusetts. This does not include the non-infectious alpha-gal syndrome, which we also have to be thinking about now. But Lyme disease remains sort of our number one in terms of human disease by far. And you can see that in this graph here. So this is back showing Lyme disease cases from 1990 through to the current day. And you can see both babesiosis in blue and then anaplasmosis in the sort of maroon color, have been coming along, but remain at much, much lower levels. Now, there is some surveillance changes over time, which sort of explain some of the ups and downs here. But what I want to really highlight is that a significant part of this increase from 1990 up until today was geographic spread of the tick, right? It really started down in the Cape and Islands and then has become endemic throughout the state. And so just want to show a series of slides with kind of demonstrating how sort of widespread these diseases are, and that they have been for a while. It's not just recent. That even back in 2010 through 2014, you can see the incidence rate was pretty it was occurring. We had cases throughout Massachusetts, and that remains true today. There's been a little more change with babesiosis and anaplasmosis, but again, I just want you to look at Berkshire County, the difference between the earlier slide map on the left to the current one. That we can see that this tick is now spreading disease across the state. And same true here for anaplasmosis. And so this is entirely different from EEE, where we really have sort of geographic pockets where we can say this is really where disease is happening. I mean, yes, there is variability in case counts. You can absolutely see that on these maps, but it's not like there's zero risk in between the hotspots. And we can't really do surveillance for ticks. Ticks don't fly, there's manual collection. Tick populations are variable over time and space, and even at very small scales. If you go down like my street and look at different people's yards, you will find different populations of ticks in each yard. And so although at a human population level, the size of tick populations is somewhat correlated with case numbers. So if you look at like a state that has a lot of, infected deer ticks, you will see a lot of Lyme disease cases. But if you look at that on a micro environment scale, it's not consistent. And so we do not have an effective tick surveillance system to drive risk communication, and that is very different from EEE. Ticks are common every year across Massachusetts. So we do look at emergency department data, and we can sort of track over time visits where the word, tick appears. That doesn't necessarily mean that there was a disease diagnosed associated with it. It may just be tick removal, but we can use that a little bit as our more timely surveillance tool. But again, if you look at the data, geographically, you can actually see that, it's happening across Massachusetts. And so that makes it very hard to be able to kind of tailor your risk communication message. And so our risk tools are, insect repellents, tick repellents, putting your clothes in the dryer on high heat after you come inside, showering or bathing quickly to wash ticks off you, to do tick checks so you can find a tick quickly and remove it, and then also talking to your healthcare provider and veterinarian and making sure you're using tick prevention on your animals. So I think the communication challenge for Lyme disease that is similar to EEE is that prevention relies on action by every individual, and actually layered prevention strategies are best. And, that's just hard for people. But then some of the unique communication challenges are that there's no real way for us to detect or talk about escalating or de-escalating risk. The risk is geographically extremely widespread across the state, and any variability that we see in sort of case numbers doesn't really change our risk communication messaging. We still need you, right, to pay attention and to take steps to protect yourself. The tick season is so long, and it's getting longer with climate change. It goes March through November, December, right? And even in warm January, February, you can find ticks. And so having to sort of like talk about ticks for that length of time and ask people to do things is very challenging. There's really limited ways to assess variability between years. And again, any variability in the tick population does not change our risk communication messaging. We don't have any new tools to prevent disease, which would, be exciting for people. And there are no effective tick population control measures. So I just want to end here and say, and this is really just sort of me personally based on things that I have learned over the years. So there is some cognitive dissonance, I find, where we're spending so many resources on a disease that has a very small number of cases, EEE, although again, very severe, versus our tick-borne disease. But it's really because we have more actions to be able to impact and affect the risk from mosquito-borne illness than we do for tick-borne diseases. And so it's not about number of cases, it's about the tools in the toolbox. And this is just me. I said I wasn't going to talk about risk communication principles, but the most important risk communication principle I have been taught is that when people are scared, upset, or stressed, They want to know that you care before they care what you know. And so I try very hard to remember that when I'm doing risk communication, particularly in person with groups. And I try to be honest and earnest and listen. And I think that helps. And then the most important risk communication principle I've learned over the years is that nature abhors a vacuum. Even if I don't think something is important, if people are talking about it, I need to talk about it also, because otherwise somebody else is going to step in and I may or may not like what they're saying. And so I think that is also very important. So I'm sorry, I always talk way too much. It was a lot, but if there's any questions or comments, I would be delighted to hear them.
Thank you so, so much. I learned several things that I did not know before, both about like the measures that the state and the different communities take on this, but just also about some of these diseases. Folks, feel free to drop any questions or comments in the chat or the Q&A box. I think one of the things that really popped out at me, Dr. Brown, is like the work that the state has done to push out information, and you kind of showed both on the risk, right? Like what are the communities at risk, but then what are those steps? And I think, as you said, there are more for the mosquito-borne diseases. And then, starting to answer the questions for folks so they understand what those mitigation measures mean for them and their health. And looking at the impact on, ED visits relative to spraying times for people that may have concerns about the interventions that are being done to prevent these. So I think that those tools and resources are really impressive. Are there any things, I'm sure like analytics are tracked, that folks have seen that get more traction or engagement from the public?
You know what? I wish I could say that data was driving the interest, but I would say it's probably not the case. So stories from affected families really do drive interest, which I think can be both helpful and damaging sometimes, depending on the situation.
Yeah.
We have historically actually used some PSAs from affected family members of EEE patients that I think were very compelling. But in the day of social media, we find people are less willing to do that because then everybody has their opinion and they tell them about it, and it can be hurtful, I think. So that has been problematic. And unfortunately, the things that I think on the tick-borne disease side that really grab people's attention are the scary things, like the, oh my gosh, Powassan virus can be transmitted after only 15 minutes. Well, we don't actually know that. And that's not actually the message. The message is, here are the things you can do to avoid tick bites, right? And I think alpha-gal right now is actually grabbing attention in much the same way. I'm actually trying to leverage that a little bit because of that nature abhors a vacuum thing, right? If people are interested in alpha-gal, let's talk about it, because a lot of the prevention tips are exactly the same. And even though they're boring, and I've been saying them for years, maybe newer people are hearing them now because they care about alpha-gal.
Yeah, no, I think that those are sort of great points, right? And where are those common messages where you can leverage, the situation of the moment, or the thing that is getting attention at the moment, to push some of those communications through. I also think, as I look at some of our audience and recognize we're right at time now, I think some of the tools and resources you shared here are really helpful for healthcare providers to kind of continue the conversation on risk with families, and being able to kind of, have those one-on-one conversations in a provider-patient relationship too. So I think knowing that these exist and that healthcare personnel who are in active clinical practice can leverage them is really helpful.
Yeah, I know clinical practice folks always have way too many things to address, and I don't necessarily think that, ticks or mosquitoes will be top of their list, but at least we try to have information available so that if it's appropriate, they have access to it.
Definitely. Well, I recognize we're at time. Thank you all for joining us today. Again, if you're looking for contact hours, don't forget to engage with the texting app to receive those. And Dr. Brown, thank you so much for sharing your time with us.
Thank you, Eileen.